I looked at my objectives for clinical performance assessment in an hour and realized that they are very lofty. So I've been thinking about what are really the essences of clinical performance assessment and how might you evaluate them. So the first tenet of clinical performance assessment is observation. Long before there were standardized patients, long before any of that occurred, observation was the way that we helped learners learn about clinical performance assessment. There are, however, some, oh, there's Dawn in the chat. So there are some advantages to observation and there's some drawbacks to observation. So an obvious advantage is if you're observing, you can give immediate feedback to the learner about what you see. And, oh, there's Wendy. Hi, Wendy. And that's a good thing, right? The bad parts about observation are they're time intensive, thus they're expensive. It's usually one-on-one observation. And the other problem with observation as clinical performance assessment is that it's not reliable. Sorry. So I might observe a interaction and think my feedback would be X, and Vicky might look and her feedback might be Y, and Wendy might look and her feedback would be Z. That's because we all are individuals. We all pick out important parts that we think are important, but they're not often the same. And sometimes the same the same observational unit can be evaluated by different observers completely differently. This is why, what's the word? In-person testimony, you know, like I saw this robbery occur, are notoriously unreliable because in the heat of the moment, people notice different things. And as time goes on, those things morph and change. So you need two things, which are the other two tenets of clinical performance assessment. So you need observation, but you need multiple observations, and you need them done immediately after whatever performance has occurred. So you need to look, you need to get multiple looks, and you need to have it done immediately. There are tons of data in the clinical performance assessment literature, much of it written by my former mentor, Reed Williams, about how fast observation denigrates, memory denigrates over time. So for example, you might be able to give very concise, very specific feedback as the learner finishes an interview. But if you were to ask to give feedback about that interview to the student 2 weeks later, all you would probably have left was a general impression, unless something either incredibly good or incredibly bad happened. So you need to give that observation immediately. You also have to give that observation, you have to have multiple observations for a reliable result. So it's very variable how many in the literature observations you need for a reliable result. So for example, to ascertain whether or not a student asked a particular question might only need one observer. To assess communication skills and attitudes with the patient, etc., requires over 30 observations, 32 to be exact. And in the middle, to allow for baseline differences in raters and the context specificity of cases themselves, you need to have at least 12 to 14 standardized patient cases if that's what you're using. And that's exactly why our summative CCX uses 12 to 14 cases, because it provides you a reliability of judgment around 0.8, which is equal to some multiple choice examinations. So if you remember nothing else about clinical performance assessment, remember those three things. And then watch in your clinical lives how often those things are not done. And when they're not done, you can't rely on them. So if it's one observer of one instance who doesn't give the feedback until 2 weeks later, it's basically useless feedback. That's one of the reasons why in our clinical clerkships, we've changed from a summative assessment to a narrative assessment in much more coaching style, which occurs immediately after a clinical encounter, because those are more reliable. And the more reliable they are, for high stakes examinations, it's obviously important, but the faster they are, the more it helps the learning of the particular student. And we have basically built clinical performance assessment at SIU around those tenets. If you remember nothing else, when you go to build standardized patient cases, et cetera, remember those things. You can't just run 2 standardized patient cases and make a high stakes summative decision. You can't observe and then report to the student 2 weeks later about the performance, unless perhaps you've written it down immediately and then give it, right? You can't do it. It won't, it's irrelevant. And you have to have more than one person look and more than one case if you're going to build a high stakes test. Any questions about that? Okay. As you can, please feel free. As you can imagine, there are tons of papers written about clinical performance assessment, and they go back far. Actually, the first person to do a direct standardized assessment of clinical competence, to develop that program of standardized patients, was here with Howard Barrows and Reed Williams. And their first paper about it came out in, about the whole standardized patient system, came out in 1987. And Williams and Barrows were the first 2 authors. And it has remained sort of the pinnacle of information. It's called the Direct Standardized Assessment of Clinical Competence. And it's Williams is the first author, Barrows is the second. So there are, however, discussions of standardized patients and what works and what doesn't by Howard Barrows in the late 70s. So it's been around a while. SIU has the longest standing standardized patient program in the country. And we continue to kind of lead the pack. Matter of fact, SIU was behind some of the methodology for the old Step 2 CS. And it was behind, obviously behind the methodology for the DXJ, which I invented, which we're going to talk about in a minute. So what do you have to consider? So basically, standardized patients are the sine qua non of clinical performance assessment. Why? Because you can make sure that each student sees the same case and that the case is represented with high levels of validity throughout. Whereas you can't really compare, like Tyler, if I asked you to see a patient with mania on day 1, and I asked another student to see a patient with mania, a different patient, day 2, you could not compare their performance because patients are complicated and they don't all share the stories equally. They're not all forthcoming, et cetera, et cetera. So it's really difficult to evaluate student performance on a patient of X kind if they're all different patients with the same diagnosis. So standardized patients are the quote unquote easier way to do it, higher reliability. The downsides, of course, are time and cost. And there are also all kinds of arguments against standardized patients and their use. Hang on a second, I gotta grab a paper. Bandied about, and actually 1979, Howard Barrows wrote an editorial about that. The most common argument against using standardized patients in clinical performance assessment is that the simulated patient is not a real life situation and is too artificial to use on candidates or students. There have been multiple studies about this, that expert clinicians seeing patients in clinic cannot recognize a well-trained standardized patient from real patients. I see students often using this argument that you can't use standardized patients because they're artificial. And I think many of them are doing it for defensive reasons. It's not the standardized patient that makes it difficult. It's the fact that they know they're being observed that makes it difficult. I mean, I don't like being observed live either, but it was a part of my medical school training, and I didn't have nearly as much as medical students have now. And so the upside is it trains you better. The downside is it does come with some anxiety about being observed. But as a clerkship director at U of I in Chicago, I had a series of standardized patients come through our outpatient psychiatry clinic, and neither the students nor the residents could recognize which ones were standardized or not. So the fact is, well-trained ones are indistinguishable. And also, if you've experienced good ones, you get in and it feels artificial, and about 5 minutes in, it feels real. And I don't know, Tyler, if that's been your experience seeing standardized patients, but that basically the literature supports that. There's also some interesting literature that supports those students who can't withhold their belief in reality long enough to work with standardized patients also have trouble with real patients. So we worry about those. Let's see. I mean, the other big argument is that they're too expensive and they're impractical. And I think we've shown here that, yes, they are expensive, but they are practical. And I really believe that when we graduate our students, we have a handle on their ability to handle a wide variety of patient cases at a competency level. And certainly our graduate reports from residency directors back that up. So how do you go about writing a standardized patient case? Well, if you want to do it the easy way, you talk to Mary Alio or Amelia Frank in our Office of Education and Curriculum, and you ask for the case blueprint. This has been developed here over a number of years, and we use it for every case we write. I sent an example to you earlier of a case called Paul Knight, and you can see that basically everything is included in this case that you might need. And if you were to fill out a template of this, obviously you wouldn't forget important pieces. We have over the years, increasingly when we write these cases, used evidence-based medicine references where possible, so that we're doing state-of-the-art treatment, diagnosis, etc. of these patients. But I would turn your attention to page 2 of that document, where it talks about key findings and diagnostic hypotheses. And the key findings are crucial when we're going to talk about grading the DXJs, which we're going to move on into. And the diagnostic hypotheses are crucial when it comes to coming up with a differential diagnosis. So if you look at page 2, you'll see that key findings in this particular case, there are 18 of them. One of them is 0 weighted. You can ignore that. That's for a different part of the clinical competency exam. But for the point of the DXJ, we use all of those key findings. And then you can see that there are 7 diagnostic hypotheses for this case that were presented, written by the authors as these are the key questions that you need to ask or key physical exam that you need to do. And out of all that information, these are the key diagnostic hypotheses that you should be coming up with. Okay, so if you look at those 2 findings and then you turn to the diagnostic justification article or 2 pages that I sent you, on the 2nd page, you can see the diagnostic justification evaluation form. And you can see that there are 3 questions, right? Can everybody see that? Hopefully you've got those. Okay, so the first question is on differential. So based on the diagnostic possibilities discussed, did the student consider an appropriate range of diagnostic possibilities given the findings of the case? So you can see that differential directly correlates to the diagnostic hypotheses section of the case write-up. So how do you determine an appropriate range? Well, this basically, I've graded by my last count over 9,000 DXJs, and I've gotten a feel for how students should perform. I don't expect students to perform at the level of a faculty member, obviously, but I'm not going to dumb down anything either, because, you know, taking care of a patient is taking care of a patient. And if you can't do it, it's just as important if you can't do it as a student. So how do I set the grading for these? What I do is I round, if it's a even number, I take exactly half. If it's a odd number, I round up by 1. So for the diagnostic hypotheses, I would say 4 to 6 would be competent. 7 to 8 would be excellent. 2 to 3 would be borderline, and less than 2 would be poor. And those are sort of just a ballpark. I've just been doing it so long, that's about how I do it. I take half, anything above half is competent, and then at the upper levels of that half are excellent. Anything below half is failing, and they are stratified into 2 levels, either borderline or poor. Similarly, with key findings, it would be 9 to 13, 14 to 18, 6 to 8, and anything below 6 to set those grading levels. Now, do those absolute numbers mean anything? No, I've picked them out of my head, except for the halfway point. You can divide the half into its two components with any numbers you want, as long as you're consistent across all cases. So it could be 9 to 12, competent, 13 to 18, excellent. You can do it however you decide, but obviously you have to stay consistent. All right, so I sent you a case of a student. Did I send you one case or two? What does your Paul Knight case say at the top? Does it say M student or does it say student P?
Student P.
It says student P. Okay. All right. So let's look at student P's case. Up on the top, there is the students list of diagnoses. And on the right is the gold standard list. All right. So what you do is you match left to right. So carotid artery occlusion, is that one of the diagnoses listed in the gold standard?
No.
Okay. How about unstable angina?
Yes.
Correct. How about temporal arteritis?
No.
MI.
Yes.
MI is listed, but note that you've already listed, given a credit point for unstable angina. And all those are included together. So you would not give another point of credit. You would just give them the credit for one in that list. And then atherosclerotic coronary disease. Is that in there?
No.
Okay, so this student would have gotten 1 out of 7 possible diagnostic hypotheses. So what would his or her, I don't know which it is, score be?
So can you tell me, Deb, why next to 6 and 7 it says 0?
Just
Because they
ignore
didn't
those.
guess it. Okay, I see what you're doing.
Yeah, just ignore those. Those are used in another part of the CCX program. We don't need to use it.
I'm gonna say the score is poor.
Okay, the score is 1.
Oh, okay, I'm sorry, I converted, sorry.
Yeah, so the only point this student got was unstable angina / MI, right?
Yes,
Okay, so 1 out of 7 gives you a score of 1, which is what on our grading rubric?
borderline.
No, it's poor. Because we said 4 to 6 was competent, 7 to 8 was excellent, 2 to 3 was borderline, and less than 2 was poor. And he got a score of 1.
Okay.
Make sense?
Yes,
Okay. So he's not, she's not starting out very well. Okay,
Deb,
Now-
what does the MSL stand for?
MSL.
You have score 5 out of 5.
Oh, minimum standard of something. You can just ignore it.
Okay.
Yeah, that's all part of the other CCX program, but not for the DXJ purposes. You can basically ignore all that. Okay, so what happens next is there's a lot of interview history and physical by the student, and under diagnosis performance, you'll see they've got their diagnosis was stable angina, substernal chest pain brought on by stress, relieved by rest, increasing in frequency but not duration or intensity, atherosclerotic coronary disease is probable and contributory. The actual diagnosis is acute coronary syndrome. But note on the DXJ, there's no score for a final diagnosis, right? We don't care what the student's final diagnosis is in the DXJ, because the DXJ is measuring clinical reasoning. And when students do these cases, they are right. They get the correct diagnosis 99% of the time. Why? Because A, we don't make ridiculously hard ones. We're not trying to trick the student. We don't have weird zebras. And B, the students have access to labs. And even if they have no idea what they're doing, if they shotgun labs enough, they can usually get the correct diagnosis. So we don't even use it in our clinical reasoning rubric. However, the next part we do use. So the key findings directly correlates to the key findings in question number 2 of the DXJ. So there are 18 key findings listed. 9 to 13 will give you a passing competence score. 14 to 18 will give you a excellent. 6 to 8 will give you a borderline. Less than 6 will give you a poor. Gesundheit, Tyler. Okay, so what you need to do is read through the key findings, and you'll see these are the findings that the case authors thought were important to include in their differential, in their history and physical. And you can see they're usually, the history parts are listed first. So the history goes all the way down through 12. And then 13 through 18 are physical exam issues. And I point that out only because as you're grading these, it's kind of helpful as you start doing a bunch of them to remember what the key findings are. Because when you first start with the first case, it goes quite slowly. But for example, when I'm grading the DXJ, the summative CCX DXJ, and there's 75 of each case, by about case 5, I've memorized what all the key features are, and then I can just go find them, no problem. But it's going to take us a little bit to do this one. So I include anything that the student writes, even under the final diagnosis. So if there are any findings in the diagnosis list, like this student has a long description, if there's any findings in there or in the DX justify performance below it, circle them and refer to key findings in the gold standard as your list. Okay, so read through everything on the second half of the student's page, circle anything that is a key finding in the gold standard list. Two and 3. And then under the paragraph, the radiation is number 4. The patient's diabetes is number 8. And the fact that he's a smoker is number 10. I don't know where you got hypertension. Did I miss it?
In the DXJ performance, I think he
Yeah.
says, or the student says, it's like a few lines down. The presence of shortness of breath goes with this diagnosis, history of DM, hypertension, and tobacco smoking.
I.e., a student who really understood clinical reasoning should be able to say something, and I'm just totally making this up. Here's my list of differential diagnoses. For diagnosis number 1, the patient has X, Y, and Z and doesn't have A, B, and C, which would point you to a different diagnosis. And then they'd go through all of the differentials just like that, using what we call symptom constellations. So you don't want a student to say, I think this patient has an MI because they have chest pain, period. I think this patient has pneumonia because they have a fever, etc. There are so many other things that it could be that you need to show these symptom constellations. And usually I look for 5 or 6 pieces of data. So like this student, a good student might have said, I think this patient may have an acute MI because they have chest pain. The exertion makes it worse. It's increasing in frequency. It has radiation to arms and the neck. However, and there is no presence of pleuritic pain, no leg pain, no fever, etc. And they go through each differential diagnosis like that. But this student basically says, gives you a discussion of angina that is, the fact that it radiates to neck and both arms is an unusual presentation for angina. But the location with exertion and relief with rest are hallmarks of stable pain. So basically using 2 things. The diabetes could account for atypical signs. And then he dives into labs and imaging to save himself. He's not reasoning with any of the key findings that he should be using to reason with. In fact, he didn't do any physical exam at all, or if he did, he didn't report it. So you basically have to decide, did this student make a logical argument using history and physical findings to rule in and rule out his various diagnoses? So what would your answer be to that?
4.
Yeah, poor. That's why, by the way, there's a P in there behind the student. Okay, this is a poor argument. It's a poor DXJ. So this student would have gotten poor, then borderline, then poor. And if you look at the reasons under number 3, you could basically say the student failed to use constellations of findings that are indicative of medical diagnoses. The student failed to actively and explicitly address disconfirming evidence. The student failed to explicitly address pertinent negatives. There were a whole lot of things that this student did, but basically they were bad, poor or borderline. Nobody would argue, would you, that this student should pass question 3?
So Deb, if they didn't do well in 2, more than likely they're not going to do well in 3.
That is correct. That is correct. Usually, well, and what's interesting is since we've been doing the DXJ for a long time now, and there's a summative CCX that occurs that students know they have to pass, student performance, and we have DXJ used now throughout the curricula, year 1, year 2, et cetera, the performance on DXJs is dramatically increasing. So This student was a fourth year student back in, I don't know what year it was, but it was before the new curricula. Now, I almost never see in a senior student poor or borderline reasoning. Almost never. On occasion, I still do, but almost never. Where students fail is either in their differential diagnoses, they don't have enough or they're inaccurate, or in the findings. Usually they don't have enough. Because part of the problem is when students work with faculty who are experts in their field, experts don't reason like students do, right? Experts use pattern matching. So for example, if a patient walked into my office, within 2 questions, I would have a really solid guess that this student is, that patient is schizophrenic. And it would take me maybe 5 more questions to be right, to assure that I'm right. Students don't have enough experience to pattern match, so they must use an analytic style of problem solving. And that is just exactly what I've described in the DXJ. It's a logical argument for and against a variety of different diagnoses. So in some respects, in the clerkship years, it is harder for students to learn clinical reasoning if they're just emulating their attendings, which is why we start this work earlier, which is why we have the triple C's so students can see reasoning happen in real time among physicians. And even then, when we filmed those physicians for the triple C's, we had to remind them ahead of time to try to think like a third-year student, not like a faculty, because they wouldn't want to ask enough questions. So that's how to grade a DXJ, and that's how to understand a DXJ. You can then start from there to diagnose problems with clinical performance in the clinical reasoning aspects with the DXJ. We also assess other kinds of performance with the DXJ. With the clinical competency exam. For example, we evaluate student communication with a patient by having the patients fill out patient satisfaction scores. And that, again, is an incredibly important part of a student's ability to interact, or a resident's, to interact with patients. So we want to pick up students who have problems with that very early so we can help. Clinical reasoning, we try to teach explicitly from year 1 onwards, because we have done internal studies that have been published that show that clinical reasoning skills do not increase in the clerkship year. We all thought they did, but the fact is they don't, because they're either emulating their advisors, or they're getting a hold of charts where information is already there, or they're listening to their team. So across the 3rd year, it's mostly flat. Where they're really growing in clinical reasoning is in the first 2 years of medical school. And we've actually had a consortium of 6 medical schools look at this, and the findings are the same across all medical schools. So that is why we changed the 3rd year clerkship to be much more about immersion and finding your people than it is about seeing particular patients, and have moved to training students using the triple C's so that we can guarantee all students have worked through the same 144 diagnoses. All right, what questions do you have?
So a student that's struggling with this, do you have them to watch the CCX videos, or are there videos that they can utilize?
They can. Usually what we do is for
I know
students,
you have the remediation class, but are
right,
there any like hands-on tools that they can go back to review?
well, in the first and second, the 2nd year particularly of the traditional curriculum, students all have nurse educators, and I know, Tyler, you have Jen and you have Dawn and you have a bunch of people who will go through your CCX and talk to you about your clinical reasoning. And our nurse educators do that. They have the case, they have everything in front of them as well. And so we pick up students that way. We also have the triple Cs that have the faculty discussing their differential diagnoses and why after the student has input theirs. So it's kind of an immediate feedback loop. And then in the summative CCX, if you fail the thing, there is a 3-week full-time remediation course. Interestingly, in the past 2 years, there have been no students who have had to take, or at least last year, there have been no students who've had to take the clinical reasoning in and of itself, the elective course. And that's because when you look at all the data from the summative CCX, which is, history, physical, patient satisfaction, everything, plus clinical reasoning, one, I told you the students have been getting better, and two, not all failures are a result of clinical reasoning. And oftentimes there are failures in knowledge. And if they're failures in knowledge, but not clinical reasoning, this course isn't going to help them. Instead, they meet with me, have a one-on-one evaluation of their overall performance, identification of weak spots, and then we basically write a contract, the two of us, about what the student is going to study in the areas of knowledge that we meet later and make sure those have all been learned. So unless it's the specific clinical reasoning problem, then there's no reason to take the clinical reasoning course. There are other methods of remediation that would be more effective and less time consuming.
Right. Are you